Welcome back to the nuts and bolts of MACRA. During our last session, we reviewed the history of healthcare reimbursements and the trending movement to pay providers for value rather than volume, evidenced by the PQRS, meaningful use, and value-based modifier programs. During this session, we will spend the next 15 minutes or so explaining the legislation of the Medicare Access and CHIP Reauthorization Act of 2015, commonly known as MACRA, and discuss how it will change future healthcare payment models. We'll show why and how the legislation passed and what it really seeks to accomplish in the coming years. Let's start with the details on how MACRA was passed. On April 14th in 2015, an overwhelmingly bipartisan majority in Congress passed the Medicare Access and CHIP Reauthorization Act of 2015, or otherwise MACRA. President Barack Obama signed MACRA into law shortly thereafter on April 16th of 2015. Now, what did MACRA authorize? In a nutshell, MACRA, 1, repeals the sustainable growth rate, or the doc fix. It combines PQRS, meaningful use, and value-based modifier into a single program called MIPS. It introduces 2 tracks of payments in the new quality payment program, MIPS and advanced APMs. 4th, establishes a 0.5% physician fee schedule update each year for years 2016 through 2019, and proposes no updates to the Medicare physician fee schedule for years 2020 through 2025. I think it's important to take a moment to look at how important it is that MACRA received such strong bipartisan support. It was approved 92-8 in the Senate and 392-37 in the House of Representatives. This indicates that the next administration, whomever it will be, will not do away with MACRA. Congress understands that healthcare spending is out of control and knows that the sustainable growth rate was not an ideal way to affect change in overall healthcare spending. So we have over 300,000 Medicare beneficiaries in the state of Nebraska, and I'm curious, from your perspective, we have an urban view and a rural view. What impact do you think MACRA, MIPS, alternative payment models are going to have in your community as it takes traction in how providers are being compensated?
You know, I think from my point of view, now granted, my point of view is driven by an accountable care organization and Medicare shared savings, is that now we start to look at the entirety of a population. Granted, in the Omaha Council Bluffs market, this is a subset of the population of the rest of the state. But now you start to look at the disease burden that happens within that population, because before, as we deal with our patients, we deal very much one-on-one. We never take a step back and look at the whole forest. We're always paying attention to those individual trees. Well, what all of this is going to do in the future is have us take that step back and say, this population is heavily burdened with disease. Almost 50% of the people in the state of Nebraska have hypertension, for instance. And this is a population in Medicare world that we're going to have to learn to manage. The other thing that is somewhat disturbing to me is if you look across the state in the Medicare group, that about 11% of the Medicare beneficiaries don't participate in any E&M services over the course of a year. And so you have 10 to 11% of the Medicare population that doesn't come in to see their physician. I can't imagine that there's 10% of that population that is completely healthy and doesn't need some sort of oversight. So, I really look at this as the chance to start to step back and look at these populations and what disease burdens they're really carrying.
So that's 30 to 40,000 people across the reach of Enhanced Health Network, for sure.
Yeah.
John, I'm curious from your perspective, smaller community, what you think this may mean for your community.
Absolutely. Mike hit on a key point, and I think it's one of these social issues that's recently been acknowledged, but in some recent literature that I looked at, about 10% of the Medicare population, they may already have a primary care doctor. They don't access the system. And I think the opportunity that's embedded within MACRA, I'm most intrigued by this clinical practice improvement activity, or now the improvement activity, because central to that, Mike just hit on this, is the imperative is there now that healthcare systems need to work with their community resources. In our community, it's very apparent we have some fairly significant social issues. It gets into those outcomes that we can't necessarily impact, but our partners within our community can. How are we addressing transportation issues for patients that can't get to the hospital? How are we working with our local public health department such that we can get into that demographic that may be kind of hiding at home, that's an eventual health issue, catastrophic or not, that hasn't even been on our radar. So I think this gives us the chance to take a proactive model. I think it's something that primary care and smaller communities have struggled with, because you're so overburdened by the sort of first come, first serve approach. If we can get into some of the data, dig into sort of more of a demographic profile, I think we're going to see there's an opportunity to get into that upstream model that we don't have that much experience with.
Yeah. Another point I'd like to emphasize is the flat 0.5% increase to the Medicare physician fee schedule through MACRA. When you consider your increasing costs through cost of living and other administrative costs, providers stand to lose financial ground with that flat fee schedule unless they focus on succeeding under MIPS. Now let's talk about the two tracks for providers to work in designated by CMS in the Quality Payment Program starting in 2019. The Merit-Based Incentive Payment Program, or MIPS, and the Advanced Alternative Payment Models. We will spend the next 2 sessions going into further details on MIPS and Advanced APMs. But here is the overview of both tracks. Most providers will begin in MIPS. An important note is that the beginning performance year in which CMS will rate providers is just around the corner, starting January 1st of 2017. Providers will be annually rated on a competitive 100-point scale across 4 performance categories, which for the 2017 performance year can result in a potential incentives of an estimated 4% of Medicare Part B for providers reporting a full year of data per CMS's 2017 MIPS participation options, otherwise known as pick your pace options. Incentive amounts may be somewhat lower in the first performance year than originally contemplated. Providers reporting less than a year of data in 2017 should expect a lower incentive potential than those reporting a full year. As long as some data is submitted for the performance year in 2017, a provider can avoid financial penalties under MIPS. In performance years 2018 and beyond, poor performance and non-reporters will be subject to penalties reaching as high as -9% in the 2020 performance year. Also note that MIPS performance scores will be published for open access by consumers, again reinforcing the reputational impact of this quality program. MIPS will be the default category that providers will be placed into, and it rolls PQRS, meaningful use, and value-based modifier into a single program to make the process more streamlined and reduce reporting burden on providers.
My hope is that at a minimum, it creates a dialogue in our peer group. One of the things I've been intrigued by is that although MACRA feels new, The reality is this is deeply embedded in a quality conversation that's been going on now for almost 20 years.
I like how you say that. That's great.
I mean, To Err is Human came out in 1999, and it really was the beginning of this conversation. And I think it's a piece that our peer group has never really been part of that conversation. You know, fast forward 18 years later, if you look at history and you look at legislative acts that have occurred, that is the direct outcome of that landmark study. It was from there that Institute of Medicine moved into the 100,000 Lives campaign. Don Berwick picked up momentum. So I think when you look at that, you know, out of that came the SEPTI model, which is safe, effective, patient-centered, timely, efficient, and equitable care. That is central to a scientific method. And you know, I think as clinicians, we're trained in scientific inquiry, but we lose sight of that, I think, in the day-to-day nuance of practice and the frustrations of payment and et cetera. But my hope is that our peer group realizes this is much more than payment reform. This is about doing the right thing for the right patient at the right time. And that language reminds me quite a bit of the Hippocratic Oath. I mean, first do no harm. So I think the imperatives have been set. Really, it's time for us to step up and say, this matters.
There are many people, many experts are saying really the only way that we're going to be successful on this journey is as clinicians step up to lead this effort. So I love how you phrase that. It is a 20-year conversation. And just as a reminder, we asked for this legislation, right? We asked for it as the sustainable growth rate formula that Doc fixed.
Yeah.
We begged for that to go away, and now it's away, and this is its replacement. The other track will be advanced alternative payment models, or advanced APMs. Providers in advanced alternative payment models assume downside financial risk based on clinical quality performance and cost effectiveness. Providers who sufficiently participate in advanced alternative payment models that are defined and sponsored by CMS will earn an automatic annual incentive of 5% for Medicare Part B payments and will be exempted from MIPS. We will explore in our module on APMs what minimum thresholds define sufficient participation. Examples of advanced alternative payment models included for performance year 2017 are the Medicare Shared Savings Program, or MSSP, Track 2 and 3, or the Comprehensive Primary Care Plus Program, CPC Plus. These contracts allow providers and CMS to share risk together, reaping the rewards of efficient and high-quality care, but conversely, sharing the downside risk as well. It should be noted that providers must qualify for approved advanced alternative payment models, and even though third parties may create APMs of sorts, only those defined and approved by CMS and meeting criteria to be an advanced payment model will qualify as a sufficiently participating provider to be exempt from MIPS. We will go into greater depth in APMs in one of the next modules.